Good morning, everyone, and welcome to today's webinar hosted by PYA. Today, we are continuing our Healthcare Regulatory Compliance webinar series with a presentation on physician compensation and the 3 R's of rural markets: reality, recruiting, and regulatory considerations. PYA is happy to present today's webinar. For your convenience, you will find a PDF copy of the PowerPoint for today's presentation in the handout section of your control panel. Before we get started with this webinar, I'd like to go over a few housekeeping items. As this event is for CPE credit, there are some additional steps we will take in order to comply with NASBA requests. Attendees will be provided 3 polling questions throughout today's webinar. Responses are documented electronically. Attendees must respond to these polling questions within the allotted time in order to receive CPE credit for this course. A post-event survey will also be provided for attendees to submit regarding their webinar experience. The polling questions and the post-event survey must be submitted for proof of participation today. You will have the opportunity to submit questions to today's presenters by typing a message into the question pane of the control panel. We'll collect these and address them by email after the webinar. All of our webinars are recorded and released with a copy of the slides after the event. With that, I would like to introduce Angie Caldwell and Martie Ross, principals at PYA.
Thank you, Laura. And as soon as I can figure out how to get the slide to move down, we'll get started. It's always something. There we go. There's Angie. Here's me. And you can see us on the screen anyway, but a pleasure to be with you all today. Thank you for joining us for this episode of Healthcare Regulatory Roundup for a topic that is near and dear to my heart, recruiting physicians and other providers into rural communities. One of the hats I wear here at PYA is the director of our Center for Rural Health Advancement, where we bring our team members together from across multiple disciplines to drill down and work on specific rural issues. And as part of that work, I have the pleasure of working with Angie on issues related to physician and provider recruitment and unique strategies for rural providers. So today we'll address 3 subjects, beginning with the realities of rural medicine, focusing then on physician recruiting in rural markets, and then a drill down in a case study on best practices and valuation considerations. So let's talk about the realities of rural medicine. We're fond of saying here that rural is not small urban, that there are unique challenges that rural communities face. And to paraphrase former Texas Governor Ann Richards, rural health is the Ginger Rogers of the healthcare industry because they do everything backwards and in heels. And those challenges, unfortunately, are sometimes overwhelming. And many rural communities over the last several years have experienced closures of their hospitals due to financial stresses for those facilities, and contributing in large part to their ability to effectively recruit and retain providers in their communities. The UNC Shep Center for Rural Health maintains a database of rural hospital closures where they analyze the reasons for those closures, the characteristics of the communities where those closures occur. And since 2010, there have been 139 hospitals in rural communities that have closed. The majority of those have closed their doors permanently. Others have converted to other facilities. Either they partnered with a hospital and are operated then as a hospital outpatient provider-based emergency department, for example. But in many instances, these closures mean the loss of health care in these rural communities. And there's significant research over the last 20 years that demonstrate that when a rural community loses its hospital, that's the first leg of the stool. And closely following is industry, local government, the faith community, education, because once you lose that backbone of having access to care, it truly undermines the viability of that community. You see that there was a kind of a rush of rural closures at the end of the last decade, and then things slowed down in 21, 22. That in part is attributable to the significant amount of funding that rural hospitals received through the Provider Relief Fund. And those dollars really hid a lot of ills that these facilities were experiencing. And now we're hearing, as those dollars are coming to a close, that we're attempting to function in a post-pandemic world, that these hospitals are again experiencing stressors. There's a study done by Chartis Group, published in February of 2020, that focused in on hospitals on the brink. So not just who had closed, but let's take the data we know about hospitals that have closed, what their financial position was prior to closure, and let's take that information and apply it across currently operating rural hospitals. And can we identify those who are at risk? And the Chartis Group determined that there were at the time 453 rural hospitals that were vulnerable, that they exhibited many of the same financial conditions as those hospitals that had closed over the last 10 to 20 years. Of that 453, they went a step further and said there were 216 that were most vulnerable, meaning that they had indicators that were consistent with those hospitals that had most recently closed. So their financial position, ranging from the number of providers in the community to the average length of the average daily census in those facilities, their margin analysis, their payer mix, all of those factors that they looked at, they determined there were 216 hospitals that were facing imminent closure. Now again, Provider Relief Fund dollars mirrored, hid that fact for a period of time, but now on the other side, what are we likely to see with these rural communities? We can take a drill down and sort of look at the specific challenges that rural providers face, that what's unique in their communities that contribute to this potential loss of healthcare services in these communities. It begins with population loss. For a number of years, we've seen rural communities losing population, particularly younger people that move to suburban and urban areas and do not return home. Folks that have the financial wherewithal to leave rural communities, establish new homes and new lives in more urban areas. So oftentimes as they experience population loss, what is also happening in these communities is the remaining population is older and lower income. Certainly we know that that is more directly linked to greater healthcare challenges. So the population being served over time has become older, more challenges with the social determinants of health. Not always the case in every rural community. And in fact, there's been some reverse migration in more recent years as folks have been able to work from anywhere. There have been more that have returned to smaller rural communities, but again, that has truly been an exception and not a trend that has not a sufficient trend to have reversed years and years of out migrations from those communities. We have a mismatch of population and need in rural communities. Roughly 20% of the US population lives outside a metropolitan statistical area, i.e. they live in a rural setting. Despite that fact, there being 20% of the population, the rural physician market only comprises 10% of the overall physician market in the United States. So clearly 20% of the people, 10% of the physicians, there's a bit disconnect there that has to be managed in these rural communities. We've seen a growing issue with bypass behavior, that rural residents are seeking care outside of their local hospital in their local community. Out migration has become a topic of greater analysis as we've had increased access to claims data and we're drilling down on that information. We're seeing when and why patients elect to receive services outside of their home community. When we're also seeing the failure to return those patients back home. That's become more and more of an issue, that maybe a patient leaves their home community for tertiary or quaternary level of services, rather than returning to their home community for post-acute care, they'll remain in the urban setting, which creates stress on the family, often leads to higher expense, and hurts the local community because they don't have that opportunity to gain that additional revenue from post-acute care services. So we look more closely, try to understand these patterns, help rural hospitals understand why people are leaving their community, what they expect of their rural facility, being able to match that community need and the community resources more closely. Changes in healthcare delivery also challenge rural communities as we move more and more towards value-based reimbursement models and away from traditional fee-for-service reimbursement. We find that our rural providers, especially those that receive cost-based reimbursement, are being left behind because many of these models are not designed to account for a cost-based reimbursement. In many instances, rural health clinics, critical access hospitals are just left out of the opportunity for program participation because the model cannot accommodate their different fee-for-service reimbursement model. Also, rural providers are challenged by accepting risk. Certainly, we saw that with Medicare Shared Savings Program when changes were made to that program in 2017 that forced more providers to take risk earlier in the process. Rural providers were the first to exit that program. Now with proposed changes that would have the Medicare Shared Savings Program allow a longer period to transition to risk. Also proposals to afford an advance on shared savings that would provide infrastructure support for rural providers that want to participate in these programs. We hope we'll see some reversal of those trends as well. We've been dealing in a market, healthcare industry over the last several years has seen consolidation. Certainly, we're seeing a lot of commentary on the consolidation trends in our market. But certainly one reality for rural providers is being left out of that process, that as larger health systems grow their networks, they have not included rural providers. They have, in fact, promoted the out-migration problem, when in fact, what rural providers need are to be part of systems. I mean, the best role of a rural hospital and rural providers is to be part of a continuum of care and to facilitate their patients both from preventative care, interventions, post-acute care, being part of a system certainly is a critical role, but because of behaviors for economic reasons that systems have pursued, that they have not really furnished, they have not really facilitated and grown those relationships. And all too often we see our rural providers left on the outside looking in. We certainly cannot discount the impact of regulatory changes on rural providers. The cost of compliance, anytime we implement, take for example, the No Surprises Act or price transparency requirements, some of our latest and greatest regulatory requirements we've imposed on providers, again, appreciate that a rural provider with smaller staff, fewer resources, has to go through the same process of bringing their organization into compliance. And those can have a negative effect on their bottom line. State Medicaid expansion, if you remember, we talked about that 216 hospitals that are at the greatest risk of closure. 75% of those hospitals are located in states that have not expanded Medicaid. So these rural hospitals, again, remember, populations getting older, populations lower income. So we're seeing a greater uncompensated care burden in those states that have not expanded Medicaid. That they have challenges to meet their financial requirements as a result of that, that yes, there are Medicare bad debt, there's some reimbursement, but it's only 65% of the amount. Whatever you cut or slice or dice it, there's still that stress on these communities of having to provide uncompensated care. Medicare payment policy, CMS continually challenged with cost-based reimbursement. They appreciate the necessity of cost-based reimbursement. The sole challenge financially for rural providers is basic economics. It's high overhead costs of operating these facilities and unavoidable fixed costs with a significantly smaller patient population across which to spread those costs, and challenges of lower Medicare reimbursement, challenges with Medicaid and commercial payer rates, all are forcing more of these challenges to rural providers. In fact, one lesson we're learning as we analyze the price transparency data and as we analyze the transparency and coverage data, as both hospitals as well as health plans are posting information about negotiated rates, we're learning in many states that the commercial rates are lower, urban versus rural, and in some instances, the commercial reimbursement for rural communities is below their costs. So creating even more challenges for these organizations to have to face. So it is not a positive outlook given these challenges that rural communities face, and the usual urban playbook isn't going to present answers. Instead, we have to look uniquely at meeting these challenges, particularly when it comes to provider recruitment, that true lifeblood of the success of a community's healthcare system. So we'll stop here. Oops, we covered these already, sorry. But we'll stop here and get to our first polling question for our CPE. So Laura, over to you.
Thank you. Our first polling question is, do you have facilities located in rural markets? Please select one, yes or no, or not yet. Remember, you must fill out the polling question in order to receive CPE credit. You will have 30 seconds to answer. Thank you for participating in our poll. Now I'll hand it back to our presenters.
Well, not surprisingly, you've joined us today because the vast majority of you have rural providers in rural markets and are facing these challenges regularly. Yeah. There we go. So rural medicine done right is two other R's. Seems everything is an R word. It's right sizing and relationships. So rural providers are figuring out what's the right mix of services to provide locally. So that's right sizing. And then relationships is how do I add to, supplement what we provide locally with close ties and relationships with providers in other communities. So that, again, this concept of building and being responsible for a rural continuum of care and ensuring access there is access for local residents, whether those services are delivered within the city limits, or how do we make sure the transportation is available, the connection is available, access to records is available as patients move back and forth through that continuum of care. And using those limited resources as best they can. But certainly a key component of those resources are those devoted to recruiting and retaining providers in the community. So with that, over to Angie to delve into those rural realities and recruitment.
Absolutely. So we're going to start with another R. We're going to start with recruiting and thinking about physician recruiting in rural markets. So the clock, the circle and arrow clock that we've put on the screen in front of you is really applicable to any recruiting, but of course we have emphasized on this wheel for you today items that are specific and particularly important to rural providers. So if I can start at about 1 o'clock on the clock that you have in front of you with knowing your needs. So the initial response to that question of what are your needs in a rural market, you're probably thinking everything is a need. We need it all. But really focus in on what your needs are primarily in your rural market and think through that from a physician perspective. Do you have a clinical need that is unmet, a call coverage need, an administrative need, perhaps a physician leadership need that is unmet, and then recruit to that specific purpose? So thinking about that physician, that unicorn that I just described that would perhaps be able to provide all of these things, that's typically what the rural provider needs, is that unicorn that can provide clinical coverage, call coverage, administrative support, and be a real leader within the community. So then once you've defined that need, thinking about the next step in that recruiting process is you really need to be able to demonstrate resources and what support that you have for the physician. So thinking about what investments are you going to make in order to ensure that you are successful in your recruiting process. So if we go further down on the clock, we're now about at 5 p.m. and thinking about updating technology. Most of your recruits are going to be younger, perhaps in age. They are used to the latest and the greatest of technology within their academic medical centers and from their residencies. So is there an opportunity to perhaps update a small bit of technology within your facility to be able to ensure, again, that physician recruitment and show the support to that physician in order to make sure that they come to your market? Then next, know your competition. So in every rural market, that's going to be different. Perhaps your competition is 5 hours away. Perhaps your competition is only an hour away. And knowing what your competition is doing from a services mix perspective, from a technology perspective, from a new strategies perspective is going to be very important in driving your differentiation for this provider, and again, ensuring your recruitment success. So think about your competition as you are determining and as your recruitment strategy, and as a part of ensuring that you're able to do the best pitch to this physician from a recruiting perspective. Non-monetary perks, what we have seen and in our experience and in valuing and helping structure and design physician arrangements in rural markets across the country, is sometimes the non-monetary perks or the things that this physician, this type of physician, is looking for in that rural market. So think creatively about what those non-monetary perks might be. There could be lifestyle benefits that you're able to offer the physician in a rural market. This physician that is drawn to the rural market may not want the busy lifestyle that a high volume proceduralist has in a city setting. So think about that from a perk perspective. In some of our rural settings, we see a limited schedule. So perhaps the physician only works 4 days a week instead of 5. Those things can be very attractive to physicians in rural markets. And just thinking about that, again, that recruiting strategy. Easy commute is a no-brainer. I understand that I grew up in rural West Virginia, so I understand that easy commute is relative, but an easy commute on beautiful country roads might be something that the physician desires, and they are able to do that without the traffic and without all the stoplights. And so that's something that you definitely want to mention, is that the work time spent is time spent with the patient and in the clinic and not in the car. That might be a really big selling point and recruiting strategy for certain physicians. Less bureaucracy. The smaller the system, perhaps the fewer levels of review and approval that have to be garnered before something is taken care of within the organization, and that might be very attractive to a physician as well. And then back to scheduling, we talked about lifestyle, 4 days a week versus 5, or perhaps a flexible weekly schedule. Think about on-site versus telemedicine as well, which is also very, very attractive in these rural markets. At the upper left-hand side of the clock here, I want to speak a moment about the importance of physician and community match. What we hear repeatedly in rural markets is that the physician has a tie to the local community or even to the state that is bringing them home. So when a rural provider is able to focus on that community match, it makes that recruitment timeline, that recruitment opportunity, that much more likely to succeed, because this is very, very important. And we've all heard the stories about the physician coming in that didn't have a tie to the community, but really just stayed long enough to get maybe their loans paid off, and then they left and went back home. So if you can start with a physician that has ties to the community, again, that will ensure your success. At the top of the clock at high noon, I have another circle here that talks about recruiting to your strategy, which is a little bit different than knowing your needs, right? So strategy, we're thinking about long-term strategies. We're talking about organizational efficiencies and opportunities for the rural health provider. And one of those things is the new rural emergency hospital option. And if Martie is there and wants to hop back in, I would love to hear her comment on the new rural emergency hospital option.
And this has certainly been a hot topic as the rural communities have been discussing the rural emergency program. We're right in the process now of developing the regulations. We've had the proposed conditions of participation. Comments are due next week on the proposed payment model for REH. But certainly a component of those discussions has been, how do you appropriately staff an REH? How is call going to be handled? What are the responsibilities going to be there? So if you are a community that is considering this transition, be sure that as part of that process, you're considering what does the medical staff look like for this new facility?
Absolutely, absolutely, an important strategic longer term consideration. Thank you, Martie. So then thinking about the best practices for recruiting in rural markets. Some of these I've already mentioned, but I'm going to hit on a few of these as well. Use your community health needs assessment as a starting place, because that's really telling you from an overall market perspective what your needs are. So that's always a good place to start. The second best practice that we see work really well in these markets is that the physician becomes part of the community. They have that star power, and they are able then to help the community learn and grow, and they become a draw. They become part of the community, and that creates some stickiness with that physician in that community that really helps to retain that physician in that market. And so we've seen the physician become a teacher within these communities, and it really, really helps overall, not only from a physician stickiness perspective, but also from a patient stickiness perspective, creating that star power, if you will, of the physicians. Number 3, I've already commented upon, creating and recruiting physicians with a specific rural tie. Number 4, we have not mentioned yet, which is really talking about forming partnerships with local medical schools. So there are many schools across the country that focus on primary care in rural settings, and they have incentives for their physicians for then staying in the rural markets after graduation. Forming partnerships with those local medical schools, osteopathic schools, and others is a really, really great recruiting tool. And not only that, so up until this point in this presentation, we focused on physician recruiting, but I want to pause for a minute here and take a little bit of a side road, because when we think about the needs in a rural market and we're talking about physicians, we're also talking about other providers too, other healthcare clinical needs, we're also talking about the need for administrative talent in these rural markets. So while number 4 focuses on the physician aspect of this, creating those partnerships not only with local medical schools, but with local community colleges, trade schools, to build the pipeline for all of your other clinical support need. And I would even push so far to say, what if there is a partnership with the local business school to help you create that talent and bring that talent into your market from an administrative perspective, which again is becoming harder and harder to gain within the healthcare industry. And then number 5, consider stipends during residency. And of course, in any residency stipend situation, consider the time, the period, the clawback. Martie has rejoined on her camera, so she might have a comment here.
Just one comment that's been a successful strategy here, which is partnering with the B schools or with the health profession schools for internships, because the schools want to provide those practical opportunities to their students. And for you, it's great free labor, but it's also a way to introduce these folks to your community.
Absolutely, absolutely. And those folks, especially if the school is close, they have a tie to the community. So we've said that once, we've said it about 3 times, or at least 3 times now. Really important to create that tie and to create that stickiness. So I know that these are Martie's least favorite slides in the presentation, but I had to bring to the audience today some numbers, because what I wanted to do in the next few minutes is try to debunk some of the compensation myths surrounding physicians in rural market. So what you have in front of you is, I took 2020 MGMA compensation at the median. So I took 2020 so we wouldn't have any questions about what about COVID, what about this, what about that. So 2020 information from MGMA, which remember is based upon 2019 data. So this information is COVID agnostic. And then we selected a few specialties and then separated the data by rural and urban. So you're going to see that the blue bar represents your rural compensation and the green bar represents your urban compensation. So the myth is that rural physicians are really expensive. You have to pay them a lot to get them to recruit them to the market and bring them in. So what you're seeing here is that while the rural physician and or the rural APP, I've got PA for primary care, nurse practitioner for primary care on here as well. So while you'll see that the rural provider is paid more in many of these instances, it's not the windfall that we hear about or that we think about when we're looking at the additional amounts that might have to be paid to bring the physician to the rural markets. In fact, if you do the math below, if you're a fast math person, you can see that the premium in many cases, except for gastroenterology, in many cases is about $15,000, $10,000 to $15,000, which might be a little bit different than what you expected. So I'll comment upon that a little bit more in a moment. So then when we talk about productivity, the myth is that rural providers aren't that productive. So you're paying them a lot of money, but yet they're not productive. So this slide is intended to demonstrate to you, again, rural is in blue, urban is in green, that rural physicians are nearly as productive as their urban counterparts. So the myth that they're not that productive is just that, is a myth. Now, there are some things that I want to point out here. Probably the biggest difference, if you let your eye roll down the different bars, is hospitalist. Well, that probably makes sense if you think about a rural community and the average daily census and the number of patients in the beds within these facilities. Clearly, they just don't have as many beds to fill. So that one to me makes a lot of sense as far as measuring or looking at physician productivity between a rural and an urban basis or perspective. So lastly, let's talk about professional collections. So again, data is all from the same place. So this is 2020 survey data from MGMA. Rural is in blue, Urban is in green. My apologies that rural data was not reported for 3 of the specialties, but wanted to give you a complete picture for the physician assistant and the nurse practitioner in primary care, as well as endocrinology. So the myth is that you pay the rural physician a lot of money. They're not that productive. And well, they don't really collect all of that well. So what we're demonstrating to you here is that, again, rural physicians can be very productive, both in forms of from a work RVU productivity measurement perspective, which is only one measurement, and we can talk about work RVUs another day, but then also from a professional collections perspective. These providers can be very productive. And I know that Martie has a comment that she's itching to make here about just the differences in reimbursement for a rural provider.
Yeah, and Angie, you've heard me make this comment many times because the surveys are, of course, based on reported WRVUs, and we believe that reported WRVUs for primary care providers are particularly questionable because if they work in a rural health clinic, for example, or a federally qualified health center, because those facilities are reimbursed on an encounter basis as opposed to specific reimbursement tied to particular levels of E&M services, that it is likely in many instances the WRVUs are underreported because you don't have that driver that financial driver of increasing the level or capturing the documentation to increase the level of the visit. And thus, what may be recorded as a level 2 for a rural health clinic on the claim form would in another setting be a level 3 or a level 4. And so you have that undercounting of WRVUs.
Right. And so, and again, here we're showing some very good collections information for these particular providers. So thank you, Martie, for clarifying that. And I think it's a really important point because what we're seeing is that the myth is that rural providers are not very productive, but yet in fact they are quite productive, especially considering just the volume is different in their market and what they're able to garner. So if I may just have a little bit of fun with you for a minute and recast the legends that we've debunked here today. You know, if we call the compensation legend the Bigfoot legend, rural compensation is not always higher than urban compensation, and it's really not the windfall that most people expect. Sometimes it is. Everything is facts and circumstances specific. I've seen some pretty big deltas between rural and urban market physician compensation, all driven upon the Mothman, driven upon need. The higher the need and the higher the demonstrated need in a community, for example, the cardiologist in a rural Kansas community where the next cardiologist is or interventional cardiology surgeon and interventionalist is 5 hours away, clearly that's going to drive some significant compensation in those markets. So the Mothman, when that compensation is significantly higher, there's a well demonstrated community need for that service, and you can demonstrate that commercial reasonableness. And lastly, the John Henry, when we're talking about, you know, the myth, is this provider really productive? Yes, they can be very productive, not only in measuring work RVUs, but measuring the impact to the community and being that rock star community physician that everyone knows and loves and brings patients in. And then also from a collections perspective, can be very productive. So with that, I think it's time for a polling question. Yes.
Thank you. Our second polling question is, which of the rural compensations legends was debunked for you today? Bigfoot, Mothman, John Henry, all of the above, or none of the above? Remember, you must fill out the polling question in order to receive CPE credit. You will have 30 seconds to answer. Thank you for participating in our poll. Now I'll hand it back over to our presenters.
Awesome. So most of the audience at 48% said that all of the rural compensation legends were debunked today. I want to give a shout out to our moderator. It must be very hard. I'm sure this is the first time our dear moderator has ever had to read aloud Bigfoot, Mothman, and John Henry as part of a poll question. So thank you to our moderator for keeping it straight on that. And thank you for allowing me to have a little bit of fun in trying to describe all the different legends, if you will, the myths surrounding rural physician compensation. So then let's get into our case study. And the next few slides are really just going to be, they're going to be instructional. And so it's thinking about your situations and trying to put you in the frame of mind of what happens when you are recruiting this physician to your community. And think about that orthopedic surgeon that is needed in that rural market that is close to a ski resort. Think about that pulmonologist that is needed to help serve a Black lung clinic or another pulmonology function within that rural facility. Think about that general surgeon that is needed when there's no other general surgeon for miles and miles, and you have to have that call coverage. So in all of these instances, in the first box, we've demonstrated a need. Even in those opening comments that I just had, we've demonstrated a need for each of those providers. Those three specialists, while very low supply, I would say that orthopedic surgeons are not in very low supply. Pulmonologists are. Pulmonologists are in very low supply across the country currently and in very high demand. And then you know that the physician's productivity is perhaps anticipated to be lower than what you expect, especially in ramp up, and especially when you're pulling all of this together. So then what do? What happens when? So document, document, document. So the next two slides are going to help us walk through some things from a case study perspective of all of the elements that your organization needs to think about documenting from a best practice perspective. You're going to recognize some of these are valuation linked terminology. It's demonstrating commercial reasonableness, which ties into number one here. What is the legitimate business purpose for bringing this provider to the community? You're also thinking about the need. So then that goes into number two. How is the physician key to the organizational strategy? So as Martie mentioned before on the rural emergency hospital, when she mentioned that, when you have that's something that you're considering and you've developed your strategy, then tie those physicians in to that organizational strategy and document that. That's going to be very important for your recruitment case from a regulatory perspective for these rural physicians. Reference your physician needs assessment. So if you don't have a physician needs assessment, that's okay. We can help you think through the need for that physician in the community. This is different from the community health needs assessment. We're talking about really documenting the physician need in your community. Number four, referred to this on the prior slide, think about national physician supply and demand. As I mentioned, pulmonologists are in high supply and low demand. Cardiothoracic surgeons, oh my goodness, we've got lots of interventional cardiologists and we have lots of general surgeons perhaps, but not so much that cardiothoracic surgeon. So think about documenting the national physician supply and demand in line with what you need in your community. Number five is do the math about thinking through the collections, the professional collections that the physician will bring to the organization, as well as the expenses that the physician is going to have in setting up this clinic and setting up this practice. Don't hide from the loss. If your expenses are greater than your professional collections, don't hide from that. Be aware of it. Know about it from a budget perspective. CMS has given us a little bit of grace, recognizing that a physician practice loss is not an indication of something not being commercially reasonable, but it doesn't mean that you can bleed the organization financially year over year over year. So when you're looking at that physician practice income statement, ensure that it's sustainable. You might have a bigger loss over the first couple of years. Make sure that the loss that you could be getting for gastroenterology, maybe not. We saw the collections there, but with the loss that you're garnering, just again think through it and make sure from an organizational perspective that it is indeed the right thing to do, and don't hide from that loss. We've talked about community benefit before, just the services to self-pay patients in your community, the quality of care concerns, bringing that solid provider to your community so that they're not having to drive 2 or 3 hours to receive the care that they need from a specialist, perhaps. Make sure that that's documented. Document your best alternative. Go ahead, Martie.
I just say that this is also where you document out-migration.
Yes.
Because it's the ability to recapture those patients and bring that revenue back to the community and those services back to the community.
Absolutely. Document your best alternative. Your best alternative is never locum tenens, so we can all recognize that. Document your recruitment attempts. If anything that you take away today, this is something that as an evaluator that we often ask for, that it's rarely tracked. That, you know, we receive just anecdotal evidence, or it's difficult to go back and actually look at what was offered in the past. But this is creating your timeline and your support for potentially offering the next physician a little bit more to come to your community if you have a demonstrated pass, offer and then fail of that offer over and over and over time. Number 9, we talked about it earlier. What other investments have you made and investments in your facility or equipment or technology to help bring the physician in? Document that. And then lastly, how the arrangement will be monitored. No evergreen arrangements, please. We need to be looking at those regularly, ensuring that all of these things, number 1 through 9, are regularly documented from a regulatory perspective, from a fair market value and commercial reasonableness perspective, that documented and in the file for your peace of mind as well as for the organization's peace of mind. So then if we can talk a little bit about the valuation pieces of this. And so I know we're running close to the end of our time, so I am going to move at a pretty good clip, but I promise that I'm going to hit on all of these items, the next 10 items, I believe that they are. So when you're designing compensation for a physician in a rural market, of course, you're thinking about fair market value. You're thinking that the compensation needs to be commercially reasonable. Number 1, know the physician's historical compensation. It is not a crime to ask the physician what they have made historically. It is a starting point, and it is a point for your understanding to understand what a physician may or may not be willing to accept to come to your community, that you may be able to offset with some of those non-monetary perks that we talked about and some of those other things. Number 2, understand the projected productivity. Clearly, your organization is already going to know what this projected productivity is because you've already demonstrated the need. You've shown the out-migration, you've demonstrated the patient need in your community for this, and make sure that that is considered in a compensation design. We do not have to pay based upon productivity. Work RVU productivity models are great, but they're not always the best compensation structure in every situation. And in fact, PYA is starting to see movement away from work RVU based compensation models. And I know Martie will probably cheer about that. Number 3, understand professional collections. We've already spoken about that. Consider call coverage burden and intensity. If you have a general surgeon, you have 2 in your entire community or 1 in your entire community, a lot of the compensation that they're receiving is really to provide that emergent call coverage for your facility. Think about that when you're building up and understanding the compensation structure. How much call coverage comp is in the base? how much call coverage is paid additionally, and what you're going to do when we give the physician a break and allow him that so needed time off. Consider administrative responsibilities. We talked about that a few moments ago. Just a word of caution about creating a specialty medical director in a rural facility where they are the medical director of one. You can provide and have leadership roles within your organization for physicians, but you don't have to name them as a specialty medical director. It is a hard regulatory path to go down from a proof perspective that the need for the medical director of one themselves physician is needed, rather than an overall leadership, physician leadership perspective within the organization. Physician leaders are incredibly valuable in all levels and types of organizations. APP collaboration, please consider that. I know that if you're recruiting a physician to a rural market, it might be that you're not also able to financially sustain or afford an APP with that physician, and that's fine. But if you do have an APP coming along with a physician, please, please, please consider the overlap, especially if you're paying that physician on a productivity basis, because it's going to get very expensive for you, and perhaps expensive in a way that you didn't intend. If you want to know more about that, I'm doing a webinar about that actually next week, next Tuesday. Would love to see you there. We can talk about APP collaboration and the impact on productivity models. Telemedicine opportunities. If the physician is able to provide telemedicine, consider that in the compensation structure. And many times and in many instances, the value of the telemedicine service is almost as much or nearly as much as the in-office service. So please consider that when you're structuring the compensation for the physician. Sign-on bonuses through the roof, just as a note in the market from what we're seeing. Sign-on bonuses, we are seeing them as high as $200,000 to $250,000 in some instances, with large clawbacks on those. So to $250,000 sign-on bonus over a 5-year period of time. So you're locking the physician in without a payback to you over the course of 5 years. Think about those sign-on bonuses. Very important from a recruiting perspective, where we're seeing them used more and more often. Transition costs, please consider. Moving costs. We've seen some interesting and creative housing compensation within certain agreements. And then lastly, flexible schedules and minimum work standards. So allowing the physician the benefit of a 4-day work week might be a dream for that physician and a really big selling point. But think through from a compensation perspective. Are they 4/5 productive, or are they 5/5, 100% productive in a 4-day work week? Don't penalize the physician if they're able to do the work of 5 days in 4. Think through that in your compensation structure to ensure that you're not penalizing just because they aren't available. Flexible schedules, this might be really important for your rural community. Think about, again, the pulmonologist or the clinic that they're working with in coal mining communities, perhaps. You know, maybe that physician needs to serve on a Saturday or a Sunday afternoon. And so think about that from a flexible schedule perspective, and what the perhaps additional compensation would be to ensuring that that physician is available at those off times and those off hours in your community. So we've talked about everything from a design perspective as well as from a documentation perspective. Let's wrap it up, or close to wrap it up, with the third polling question. Turning it over to Laura.
Thank you. Our third polling question is, what provider specialty does your organization need the most? Pulmonology, gastroenterology, orthopedic surgery, primary care, or none of the above? Remember, you must fill out the polling question in order to receive CPE credit. You will have 30 seconds to answer. Thank you for participating in our poll. Now I'll hand it back over to our presenters.
So primary care took the lead here at 38%. There was no right or wrong answer here. We were really just wanting to hear from the audience from a rural medicine perspective where your biggest needs were today. So Martie, I think you are closing us out here.
Yeah. Just to briefly discuss the creativity that often you will face in rural arrangements, thinking outside the box. There we go. We're seeing more physician sharing arrangements, both between two nearby communities, so that both have a need for a physician, so they will jointly recruit, and either one will employ the physician and have a leaseback arrangement with the other facility, or the two will have just a straight personal services arrangement with the physician. So there's a lot of creativity in this area. In fact, one model that has been used here in Kansas very successfully is sharing the physician with the ministry. In Kearney County Hospital here in Kansas, Lake in Kansas, they've recruited a number of physicians to their community by making a commitment to share that physician with a ministry, so that they'll spend 8 months of the year practicing locally, 4 months of the year providing services through a ministry. So that's just a very creative way of meeting the unique needs of physicians as they look for ways they can move forward with their career. Also, you're seeing more and more part-time coverage arrangements via independent contractors. As you've been seeing more of these roll-up physician practices, these national firms that are placing physicians in emergency rooms or as hospitalists. Now they're even going further and looking at opportunities to place physicians in specialty arrangements, more in rural communities. And so you have someone riding the circuit, where they'll be present in a community 1-2 days a month even to provide services. They supplement that then with telehealth services. Seeing arrangements between rural communities and academic medical centers to do dedicated clinics in their local facility, and again then supporting that with telehealth during non-clinic weeks, for example. So it's really a matter of where are the resources, and how can we bring those resources into our community. It doesn't have to be the straight employment, 20 full-time employment arrangement. We're seeing more and more of these creative arrangements moving forward. And I'm sure Angie would love to assist you in thinking through the challenges, the regulatory compliance issues associated with these, but certainly never say no at the beginning. Figure out a way to say yes to these new types of recruitment models. Angie, you want to finish up with any comments, please?
Yeah, so that sharing arrangements opportunity as an alternative, and sometimes we've seen them where the physician is literally split 3 or 4 different ways. Very attractive from an organizational perspective. The physician's costs are covered by all of the various organizations, and something that should be considered, especially for your highly specialized physicians in these communities.
Great. Well, thank you all for joining us for today's webinar. Very quickly, our next healthcare regulatory roundup is September 28th. We'll be addressing the price transparency rules, the transparency and coverage, the updated final rule for the No Surprises Act. So Bob Scalzi will be leading us in that discussion. We look forward to seeing you then. Thanks, and have a great rest of your day. Laura, over to you.
Thank you, and thanks to our presenters, Angie and Martie. If you have any questions, their presentation and contact information will be emailed to you, along with a recording of today's webinar. Also, if PYA can provide assistance with audit, tax, compliance, valuation, or physician services, please call or email us. You may also visit our website at pyapc.com for more details about our specific areas of expertise, or to subscribe to receive PYA insights. Please remember to stay on the line once the webinar disconnects to complete a short survey for CPE credit. On behalf of PYA, thank you for joining us, and have a great rest of your day.